everyone, I'm Dr. Pallavi. In this video, we will be discussing the dermatology recall questions from the recently conducted NEET PG 24. So the exam has happened, the wait is over, and I'm sure you all must be very relieved. It was a different paper this time. First of all, it was conducted in two shifts. Paper 1 was moderate, paper 2 was tougher. Then the questions were also phrased in a little different manner this time, It was a little more confusing. It was more detail oriented. It asked you those tiny bits, which you get to know only when you are reading your subjects properly, you are attending regular classes, watching regular videos. So this question paper demanded an in-depth understanding of your subjects. One-liners and those revision sessions and rote learning did not come to much help in this exam. So for all of those who have given the exam, I am hoping for a very good result for all of you. But for the ones who are preparing for the future exams, I will suggest that you read properly, build your concepts and understand what you are doing. Do not just be in a hurry and do rote learning or one-liners. That will not help you as much as a proper study schedule. So starting with the discussion here, coming to question number 1, a patient presented with single skin lesion on the arm with loss of sensation, ulnar nerve enlargement, histopathology shown below. What is the diagnosis and the antigen test status? So whenever there is a single skin lesion with loss of sensation and a single nerve enlargement, we know that we are dealing with leprosy. For all practical purposes, skin lesion with loss of sensation is leprosy, especially if there is nerve enlargement mentioned. Now, when we talk about leprosy, we know the Ridley-Joplin classification. There is a full spectrum starting from tuberculoid to the lepromatous spectrum. The tuberculoid spectrum, the immunity is good, the lesions are less, the nerves are less, and there is loss of sensation within the lesion. So in this question, when there is a single lesion with loss of sensation and a single nerve, where do you think it lies? It lies in the tuberculoid spectrum. So one thing we can infer from the text is that the patient is in tuberculoid spectrum. Now coming to the histopath, in the histopath, what do we see? Here we see that there are multiple well-defined granulomas in the epidermis, and I can see a beautiful giant cell in one of these granulomas. Now again, even on the histopath basis, when you have well-defined granulomas with giant cells, you know that the body's immunity is good. So good immunity, tuberculoid spectrum. Clinical features as well as histopath, both of us take us to the tuberculoid leprosy. So coming to the options here, tuberculoid leprosy with antigen test positive, tuberculoid leprosy with antigen test negative, lepromatous leprosy with positive antigen test, or borderline leprosy with negative antigen test. See, lepromatous leprosy, it cannot be, because in LL there would be more lesions, it would be diffuse involvement, multiple nerves, and we would not see lesional anesthesia, we would see glove stocking anesthesia. So LL leprosy is out. Now borderline leprosy would not show such well-defined granulomas. They would be ill-defined, there would be onion peeling, plus multiple skin lesions, multiple nerves. So it does not look like borderline leprosy. Now we have to choose between tuberculoid with antigen test positive or negative. Now tell me, when the immunity of the body is good, it is killing the bacteria. So if you do an intradermal test with the bacillary extract, what do you expect? If the immunity is good, the test is going to come out positive. So lepromin test helps us determine the type of leprosy. If the immunity is good, the test is positive. If the immunity is poor, patient is towards the lepromatous spectrum, the test is negative. So here the correct answer is tuberculoid leprosy with antigen test positive. The lepromin test in leprosy is analogous to what you see in the MON2 test in tuberculosis. So somebody with a good immunity would have MON2 positive. Similarly, in leprosy also, if you are in the tuberculoid spectrum, this test is going to come out positive. See, coming to the histopath, in the histopath it is important to be able to differentiate. See, in tuberculoid spectrum, since the immunity is good, the macrophages will come to the area, form epithelioid cells, and there will be compact granulomas with giant cells, and the granulomas will also be abutting the epidermis. Same thing you see in the image here. You see these well-defined granulomas with giant cells abutting the epidermis. Now this image has been asked in the AIMS 2017 paper as well. So most of the questions here are, you know, not entirely new questions. In one way or the other, they have been asked across different exams, whether it be the AIMS from the previous times or the INICTs now, the previous year NEETs, even the FMG exam. So whenever you are revising for your exams, I will emphasize that you should be doing not just previous year questions from those exams, you should also be reading in detail about those topics. Now, tuberculoid, we just saw well-defined granulomas, while in lepromatous leprosy, since the body's immune response is poor, the macrophages come to the area, they do not form granulomas, they ingest the bacteria, cannot kill them, so they appear like foamy macrophages. Plus, there is a gap between this macrophage collection and the epidermis. This is called as the Grenz zone. So the findings that we see in LL leprosy, we'll see again here, foamy macrophages plus a gap between these, that is the Grenz zone. So on histopath also you can make out the difference in the two poles. Lepromin test, as I already told you, helps us determine the type of leprosy, but please be very sure of this, that it is not a diagnostic test. It just helps us determine the type of leprosy. So it will be positive in tuberculoid, negative in lepromatous leprosy. Question number 2. A patient with generalized rash on the body with a grey patch on the anal area and hair findings as shown below. Which of the following is the causative organism? Now, rash on the body, grey patch on the anal area is not giving me as much of a hint. Let us see what the image is showing us. So on the scalp here, we see there are multiple scattered patches of non-scarring alopecia. So there are multiple scattered small patches of non-scarring alopecia. If you run the list of non-scarring alopecias in your mind, when we talk about patches, in patches there is alopecia areata, there is trichotillomania, tinea capitis, then the moth-eaten alopecia of secondary syphilis. Well, it could be multiple patches of alopecia areata. TTM, it doesn't look like. Tinea capitis, it doesn't look like. I don't see any scaling or vesicles or black dots in these lesions. So I have to choose between areata or secondary syphilis. Now let us look at what the question tells us. It says a rash on the body with a grey patch on the anal area. So this seems to be something that is having a multi-systemic involvement. Not what you see in areata. Areata would be just skin. So areata is also out. Now I have to think on terms of secondary syphilis. Does the rash and the grey patch on the anal area fit in? Yes, it definitely does fit in, because secondary syphilis can have an asymptomatic rash over the entire body. The grey patch on the anal area could be lesions of condyloma later. So that with this moth-eaten alopecia could fit the clinical scenario of secondary syphilis. Let us look at the option. Staph aureus, it doesn't have these kind of clinical features. Microsporum canis causes tinea capitis, but it causes the grey patch type of tinea capitis. I don't really see any grey colored scaling here. Plus the whole clinical scenario also does not come in. Malassezia furfur has a role in causing seborrheic dermatitis on the scalp, but that would look like yellow greasy scales. It would not have alopecia. On the body, it could be causing P. versicolor, where you can see scaly lesions on the upper back, upper chest, but again not what is mentioned in the paper. So overall also it is option B, that is Treponema pallidum, which causes secondary syphilis, to be the answer here, because this kind of a clinical scenario is seen in secondary syphilis, where coppery brown macules on the palms and soles with an asymptomatic rash over the body, with lesions on the genitalia, which are the grayish flat topped papules and plaques. These are called as condyloma lata. So the grey patch on the anal area in this question were lesions of condyloma lata. This is something that I always emphasize during the class, the greyish color of these lesions. So that is what they asked in the exam also. Plus on the scalp you see these scattered patches of moth-eaten alopecia. You know why it is called so? Because moth is an insect that, you know, eats your clothes if you don't store them properly. So wherever it eats the clothes, there are small holes there. So similar to that, the scalp looks as if the hair have been eaten by an insect. So this is a classic non-scarring alopecia that you see in secondary syphilis, moth-eaten alopecia. Treatment of choice would be a single dose of injection benzathine penicillin, 2.4 million units, given IM stat. The next question here, a child with malnutrition, multiple follicular papules on dry skin on elbow and knees, alleviation of skin lesions was noted with vitamin supplementation. What is the diagnosis? So question is giving us a setting where there is a child with malnutrition and the lesions are resolving with supplementation. So definitely it is hinting towards some deficiency. You have to catch these hints in the exam. Malnutrition hai, it is responding to vitamin supplementation. Think of some deficiency disorder. Now, which deficiency disorder has multiple follicular papules on dry skin on elbow and knees? Let us look at the options. Lichen planus would show purple papules. They would be itchy, plus no relevance of malnutrition. It would not respond to vitamin supplementation. Darier's disease, I'll just show you, comes later age, second to third decade. Lesions are more on the face and the neck, not what you see here. Keratosis pilaris can definitely have multiple follicular papules, but the lesions are more on the arms, the back and the thigh. Plus, here the child would not come with history of malnutrition. The child would come with a history of atopy. Plus, they will not resolve with vitamin supplementation. So the only one that fits in this criteria, you know, we've just eliminated. Otherwise, when you look at the options, phrenoderma will be the first answer anyway. So phrenoderma is a deficiency disorder, happens due to deficiency of vitamin A, B, E, K, as well as the essential fatty acids, generally seen in children who are suffering from an overall malnutrition, comes as these dry looking follicular papules on a xerotic background, present on the elbows and the knees. It is so rough that it, you know, feels like the skin of a toad. So this is also called as toad skin. When you supplement with vitamins and essential fatty acids, it improves drastically. So this is phrenoderma. It is a direct repeat from NEET PG 22. Yes, there it was associated with other deficiency of vitamin A, that is night blindness. Here the question is phrased differently, but it is a repeat question. And so was secondary syphilis, so was leprosy. So, you know, the questions are more or less what you keep studying, just that a little more detail is asked. Now, the other options I wanted to show you, keratosis pilaris would be follicular papules with a little bit of erythema on the extensor aspects of the body. Darier's disease comes later in age, multiple warty hyperpigmented papules on the seborrheic areas of the body, like the face, the neck, the upper back, upper chest, with nail findings, with mucosal findings. So a completely different thing. Lichen planus, the 5 P's, purple pruritic papules, not what was mentioned in the question. Now, question number 4. Label the following image. So in this image, what do we see? This is the structure of skin. There are some glands here which have been marked. There is another structure here which has been marked. So it is asking, you have to label them. Let us look at the options. We have to mark sebaceous gland, eccrine gland, erector pili muscle and apocrine gland. So let us look at the question here. First of all, this is one gland which has this coil duct here and it is opening directly into the skin. So which gland opens directly into the skin? So number 2 seems to be eccrine gland. Now, what is this muscle that inserts from the epidermis into the hair follicle? Yes, you have already this option in the question. So this is the erector pili muscle. You can just look at the image and say that it's a muscle. So you mark it, erector pili muscle. Now coming to these two, this gland and this gland, which are opening into the hair follicle. Now, this we have discussed. Again, this is very minor detail that is discussed more during the regular classes. That which is the gland which opens highest into the hair follicle. This gland with its coiled, gland here opening into the hair follicle on the topmost, this is the apocrine gland. So the major confusion here is which is apocrine and which is sebaceous, while this short stubby gland which does not have a very long duct, this is the sebaceous gland, which is the option 3. So here eccrine and erector pili were relatively simple, but it was, to choose between which is apocrine and which is sebaceous. So apocrine opens the highest into the hair follicle above the insertion of the sebaceous gland. That's a very minor detail which you should remember. And let us look at the options. Number 1 is sebaceous gland. No, number 1 is apocrine gland. So this is out. Again, this is also out. Now 1 apocrine, 2 erector pili. No, 2 is not erector pili. 2 is eccrine gland. So 1 is apocrine, 2 is eccrine, 3 is sebaceous, 4 is erector pili. So the correct answer to this question is this one. So this is a very basic question here. This is how we describe skin. We have the epidermis, the dermis and the subcutaneous fatty tissue plus the glands in the skin. The sebaceous gland opens into the hair follicle, while we have 2 sweat glands. The first is the eccrine gland, which has its opening into the hair, into the skin. This has a straight dermal duct and a spiral part in the epidermis. Apocrine gland opens into the hair follicle above the level of sebaceous gland. Another question that was asked in the INI-CT November 23 paper, the distribution of the apocrine glands. So just a quick discussion of the distribution. Eccrine glands are present all over the body with a few exceptions. They're present since birth, active since birth. Apocrine sweat glands become active at puberty because they are androgen dependent. And A for apocrine, A for ANG. These are found in the axilla, nipple and the groin. They open into the hair follicle. Sebaceous glands also become active at puberty. They always open into the hair follicle, except there are some modifications. All of this you read in physiology. So the distribution of these glands and their marking on the skin is important. Question number 5. Patient with orange scaly lesion, palmoplantar keratoderma, keratotic follicular papules on the hands, and histopathology showing alternating ortho and parakeratosis. What is the diagnosis? Okay, so this question has been asked for the first time in the last many years, maybe 5-7 years, but what it is asking is something that has been in the options of many questions over the last many papers. So this is like a particular example of not just reading the previous year topics, but also knowing everything about the other options. So here there is orange scaly skin with thickening of skin on the palms and soles. That is what keratoderma is. And keratotic follicular papules on the hands. Okay, so where is all this seen? Is this seen in Reiter's disease? Reiter's disease, also known as reactive arthritis. Reactive arthritis is arthritis, conjunctivitis and urethritis. Skin lesions come. There is a word called as keratoderma blenorhegicum in Reiter's disease. But the overall clinical scenario of this question does not match that. Only confusion in Reiter's is the word keratoderma blenorhegicum, but you have to see the overall clinical scenario. Keratosis follicularis is another name for Darier's disease, and we just saw it in a previous question. This is not how it presents. It just presents with warty hyperpigmented papules. There is no keratoderma, there is no orange color of the skin, no. Now, follicular psoriasis versus pityriasis rubra pilaris. Both can present with scaly skin, both can present with palmoplantar keratoderma, but do you see keratotic follicular papules on the hands in psoriasis? Do you see alternating ortho-parakeratosis in psoriasis? You do see parakeratosis, but do you see alternating ortho-para? No. So the overall picture also does not fit psoriasis, both clinically, because in psoriasis it is more of red scaly, and you don't find keratotic follicular papules, you don't find ortho-parakeratosis. So these things are not seen in psoriasis. On the other hand, all of it fits very beautifully in pityriasis rubra pilaris. Now I'll tell you what it is. Orange scaly skin is actually the orange erythroderma, which you read as a one-liner in PRP. Palmoplantar keratoderma is actually the sandal keratoderma. Now you will remember this, very, frequently in the one-liners and the revision sessions. Keratotic follicular papules on the hands is what nutmeg grater papules are. Again, something that you keep reading. So this question actually just described the findings that you read as one-liners. Here, pityriasis means scaly, rubra means red, pilaris means hair. So here the disease starts with red scaly papules around the hair, so which are actually the keratotic follicular papules. That is how the disease starts. Gradually they keep spreading, increasing in size and number in a cephalocaudal pattern, spread so much that they cover more than 90% of the body surface area, which causes erythroderma. The erythroderma here is a little orange in color. So that is something that we keep discussing during the classes. Whereas orange erythroderma seen, that is seen in PRP. Plus, very classically, the erythroderma here has some areas which are normal in between. These are called as skip areas or islands of sparing. The skin on the palms and soles is thick. That is also slightly orangish in color. That is why it looks like sandal. So it is called as sandal keratoderma. Plus, the papules which make up this disease, they are very prominent on the hands. So these coarse texture of the granules is why they are called as nutmeg grater papules, another finding in PRP. So see how beautifully the clinical scenario of this is fitting into the question. Now let us look at the histopath. In the histopath, you see these nuclei in the stratum corneum, so that is all parakeratosis, and there is alternating horizontal and vertical parakeratosis with orthokeratosis in the stratum corneum. So this is a very classic finding. It is called as the checkerboard pattern that you see in PRP. Now, how do you differentiate PRP from psoriasis? Parakeratosis you see in psoriasis. The most important is this line here. The granular layer is normal or thickened. You see in this histopath here, you see this is the stratum granulosum. So the stratum granulosum is thickened here, while in psoriasis there is hypogranulosis. Look at the granular layer, you know you are not dealing with psoriasis. Then you don't see any Monroe's abscesses, that is neutrophilic collections in the stratum corneum. So these are two very important findings that help differentiate PRP from psoriasis. Thirdly, the suprapapillary plates are thick, while in psoriasis there is a suprapapillary thinning. So all these features in clinical as well as histopath help you differentiate. The correct answer to this question was PRP. Question number 6, very favorite of the NEET, INI, FMG, any paper you have, there will be one question on genital ulcer always. Here also there is a sexually active patient with painful lesions on the penis. What is the diagnosis? So I keep talking about this whenever you have a question to genital ulcer disease. First see whether the lesions are painless or they are painful. If it is painless, it could be syphilis or donovanosis. If it is painful, it could be chancroid or herpes. So the question here tells us that the lesions are painful, so we don't have to consider the painless options. Syphilis is out. LGV anyway does not present with the genital ulcer. The genital ulcer is painless, it is transient, patient doesn't even come to know they have a genital ulcer. So this is also out. We have to now choose between chancroid and herpes. Let us look at the image. In the image we see these multiple clear fluid filled vesicles here. Okay, they are grouped, they are on a red base. So where do you see multiple grouped painful vesicles on an erythematous base? When you see vesicles, you have to think of herpes genitalis, making it the correct answer here. A relatively simple one, I hope. So herpes genitalis can be caused by both HSV2 and 1, but more frequently by 2. You see these classic grouped painful vesicles. They can sometimes break down to form erosions. These erosions have a classic polycyclic margin. So it can present as grouped painful vesicles in the question. It can present as grouped erosions with polycyclic margins. There is bilateral painful inguinal lymphadenopathy. When you make a Zank smear, the findings that you get are: number 1, these multinucleate giant cells; number 2, acantholytic cells. So both the findings you need to remember with herpes. Treatment of choice, acyclovir. Plus it can cause recurrent lesions. Where does it lie latent? It lies latent in the sacral ganglion. So this lies latent in the sacral ganglion. Question number 7. A female presents with dysuria and vaginal discharge. Smear findings are shown below. What is the likely diagnosis? So whenever a woman presents with vaginal discharge, the causes can be candidiasis, bacterial vaginosis, trichomoniasis, or a mixed infection. What is there in your options? But does candidiasis come with dysuria? No, not much. Does bacterial vaginosis cause dysuria? No. It could be seen in trichomoniasis, it could be seen in mixed infections. Now let us see what the smear shows us. In the smear, what do we see? This is like a very beautiful smear where you see these classic flagellate protozoa here in the smear. So where are these flagellate protozoa seen, which look like a leaf? Where is it seen? This is seen in trichomoniasis. So what is the correct answer here? The smear here is helping us make the diagnosis. It is trichomoniasis. See, whenever we talk about vaginal discharge, this question was there in the NEET PG 23. Normal discharge, no alteration in pH, no alteration in flora, no itching, no soreness, physiological discharge. In candidiasis, it would be curdy white discharge with itching. Bacterial vaginosis would be foul smelling watery discharge with a positive whiff test with more than 20% clue cells in the smear. So basically in this question you had to actually choose between trichomoniasis and BV on the smear. In BV you would see clue cells. You know, just based on smear you had to choose. It would show clue cells, which would be vaginal squams studded with Gardnerella. However, in trichomoniasis, the findings would be different. The patient would present with greenish frothy discharge, strawberry cervix. If you make a wet smear, you will see these motile flagellate protozoa, and even in the stain smear, you see these flagellate protozoa. So this here, the smear makes us confirm the diagnosis. It is trichomoniasis. Treatment of choice, metronidazole. Question number 8. Identify the diagnosis. So in some recalls, students also mentioned that the question asked directly box-like biopsy is seen in. So box-like biopsy, where is this seen? Let us see. What do you see in the biopsy here? You see that the entire dermis is full of thickened collagen bundles. So if the entire dermis is full of fibrosis, that is thickened collagen bundles, where would you see that? And it also mentioned it's a box-like biopsy. So lichen amyloidosis, no, there are no such features. There's no amyloid deposit here. Lichen nitidus would show more of a ball and socket finding with granulomas. That is not what you see here. Lichen planus would be interface dermatitis with band-like lymphocytic infiltrate. No. So where is this kind of a fibrosis and box-like biopsy seen? Yes, it is seen in morphea. So on its own you may have read morphea, but to be asked in histopath like this is something that demanded good knowledge. So what is morphea? Morphea is a disease where there is localized scleroderma. Sclero means fibrosis, derma means skin. So here the patient presents with localized skin lesions with fibrosis. How does fibrosis look like? See, you would have a very too ill-defined lesion. In this skin lesion, the question may mention there is tightening of the skin. So the patient comes and tells us the skin is getting tight here, I cannot pinch the skin. So the skin gets tight, you cannot pinch. Also, another word that can be written is binding down of skin. So there is binding down, means it feels as if it has gone down, it is bound. So these are the two things that are used to describe a morphea lesion. This is localized scleroderma. In the scalp, when it happens, the lesions can extend from the forehead to the scalp. As they come to the scalp, they cause scarring, that is permanent alopecia. So you may have read morphea as a cause of scarring alopecia as well. When you make a biopsy, what do you see? First of all, you see this is a box-like biopsy here. Plus, there are thickened collagen fundals all from the papillary to the reticular dermis, extending right to the dermosubcute junction, encircling the eccrine glands, encircling the vascular structures. So that is what is a typical biopsy of morphea. This is how it looks. Question number 9. A patient has itchy lesions on his skin with blistering. He also complained of chronic diarrhea. What other findings will be seen? So, itchy lesions plus blistering. When there is itching plus blistering, what do you think? You think of subepidermal group of disorders, because there it is generally bullae with itching. Now, in the subepidermal disorders, it could be pemphigoid, bullous pemphigoid, that is, it could be linear IgA disease, it could be dermatitis herpetiformis. So these are the subepidermal disorders that we have to think. Here, this patient has chronic diarrhea. Which of these is associated with a chronic diarrhea? Here, it is dermatitis herpetiformis, which is associated with celiac disease that can present as chronic diarrhea. So what is the antibody that you see in celiac disease? That is the anti-TTG antibody. So here in the options ANA, anti-TTG, anti-DSG1, no. The correct answer here is option B, that is anti-TTG antibodies, because the patient has dermatitis herpetiformis with chronic diarrhea, which could be celiac, and thus this is the answer. Anti-DSG1 would be seen in pemphigus, but there it is painful erosions and flaccid bullae. It is not associated with itching. Plus, there is no known association of pemphigus with chronic diarrheas also. So that is out. The correct answer here is option B, anti-TTG antibody. With DH, it is important that the target antigen in DH is also transglutaminase. That is why it is related to celiac, where also you find anti-transglutaminase antibodies. Patient presents with multiple itchy papillovesicular lesions, bilaterally symmetrical on the extensors like the arm, the elbow, the knee, the upper back, the buttocks. These are extremely itchy. There is a bilateral extensor involvement and there is no mucosal involvement ever seen in DH. So the clinical features mentioned in the question also fit with DH. If at all you were ever asked the histopath, please remember in the histopath you see that this is the epidermis, this is the dermis, the split is subepidermal with neutrophilic collections in the papillary tips. These are papillary tip abscesses. When you do a DIF, in DIF granular IgA deposits at the basement membrane zone are seen. In treatment, it is important to have a gluten-free diet with dapsone. So celiac could be a subclinical involvement, it could be an overt involvement like the patient here had chronic diarrhea. Overall, whether proven or not, DH patients have to follow a gluten-free diet. Question number 10. A patient presents with skin lesions and oral ulcers. Immunofluorescence findings are shown below. What is the diagnosis? So from here, we are starting with questions that were asked more in paper 2. So these are the recalls from paper 2 here. Now, skin lesions hai, oral ulcers, immunofluorescence findings are shown below. What is the diagnosis? When you have skin lesions, which here could be bullae, since all my options deal with immunobullous disorders, so I will maybe write it as a bullous lesions with oral ulcers. This could be pemphigus vulgaris, it could be bullous pemphigoid, even linear IgA disease can have mucosal involvement in 1/3 of the cases. DH does not have mucosal involvement, so it is out. Now, what does the DIF show us? In the DIF, I see that this is the epidermis, the dermis, the immunofluorescence is in the epidermis and it has a classic fish net appearance. So where is intraepidermal fish net appearance seen? Intraepidermal can obviously be seen only in pemphigus. So what is the answer here? You know, if you just see the DIF, then also you can mark. You don't even need the clinical criteria. Out of these options, the only intraepidermal disorder is pemphigus. The skin lesions and oral ulcers fit in, the DIF fits in, so this is the correct answer. Pemphigus, as you know, is an intraepidermal immunobullous disorder where the target are the desmosomes. It is a type 2 hypersensitivity disorder. What happens is the desmosomes are damaged, the cells are separated. This is called as acantholysis. There are two important types of pemphigus, vulgaris and foliaceous. Both present with flaccid bullae. But the most important thing is in pemphigus vulgaris, mucosa is involved. Patient will come with oral ulcers, while in foliaceous there is no mucosal involvement. The DIF findings are the same in both of these. So if only the DIF is given, you cannot differentiate between them. You have to use the clinical criteria. So flaccid bullae with oral ulcers is pemphigus vulgaris. Flaccid bullae without any mucosal involvement is pemphigus foliaceous. That is when the DIF is same, you use this clinical criteria. How you differentiate? You can further differentiate based on biopsy. In pemphigus vulgaris, there will be a suprabasal cleft with row of tombstone appearance, while in foliaceous, there will be a subcorneal cleft. Pemphigus, pemphigoid, dermatitis herpetiformis, you will get at least one question of vesiculobullous disorders in every exam every year. This is a favorite with the INI and the NEET PG, something that you cannot miss at all if you're preparing for the exam. So this is about differentiating vulgaris from foliaceous. When we just see the DIFs in pemphigus, as I just told you, fishnet, intraepidermal, you will see. While in bullous pemphigoid, it will be linear IgG deposition with C3 at the basement membrane zone. Dermatitis herpetiformis we just saw would be granular IgA at the basement membrane zone, and linear IgA disease, the name itself is telling you, linear IgA deposition at the basement membrane zone. So even based on DIF, you can make the diagnosis. Now, next, a patient presents with acne on the face and the body. Which is the most effective treatment for the condition? So the image is showing us acne. We see multiple papillopustular lesions on the face with comedons. So clinically, it is not a very severe acne as per what the image recalls that I've got, and it was more of a papillopustular acne. Now, when you see papillopustular acne on the face and the body, that is grade 3 acne. In the options you have doxycycline, minocycline, dapsone. You will be tempted to mark the antibiotics. But you see that the patient has lesions on face as well as back. So this is a slightly widespread disease. Plus the question is asking us which is the most effective treatment. So it is not asking us what treatment you will give to the patient. It is asking us which is the most effective treatment. So most effective treatment in acne is anyway oral isotretinoin. It is the best drug for most severe acne because it is the most effective drug. So if you just look at the language of the question, you will mark isotretinoin. If you still don't agree with that, let us look at doxycycline, minocycline or Dapsone. All three are antibiotics. There is no way to choose which patient will get doxy, which patient will get mino, which will get Dapsone. Dapsone we don't even use routinely. It is only given to patients who do not respond to first line or second line treatment. So even in the question, by elimination, you have to give the best answer, not necessarily the correct answer here. So here, what is the best answer? For the fact that the lesions are widespread, I would give isotretinoin to my patient. The question would ask what is most effective. I would give isotretinoin to my patient. Even if I don't do all this, just by elimination, which is the better answer because I don't have any reason to choose between these. So which is the best answer? The best answer is again systemic isotretinoin. When we talk about treatment of acne, the treatment of acne is as per the clinical grading. If it is grade 1, which is a comedonal acne, treat the patient with topical retinoids, tretinoin, adapalene, tazarotene, salicylic acid, gives good result. But for disseminated comedonal acne also sometimes we may need to give more than that. However, for your purpose, remember, this is the treatment. In a question in INI August 2020, they gave an image of comedonal acne and they asked which of the following will not be given. So there was tretinoin, adapalene, benzyl peroxide and fluocinolone. So fluocinolone is a steroid. Remember, steroids are never given in acne. So there is no role of steroids. Just, one extra point here. If it is more of a papular acne, to the topical retinoid, you add topical antibiotics, which is topical clindamycin, topical dapsone, nadifloxacin, benzyl peroxide. So these are all topical antibiotics which we add in grade 2 acne. If it becomes more severe, you have pustular acne, we add oral antibiotics, which could be doxy, mino, limecycline, azithromycin, clarithromycin, dapsone. So these are all oral antibiotics that we give in acne. However, if the patient is suffering from grade 4, which is the most severe, that is the nodular cystic acne, we would require oral retinoids because this is the most effective treatment. So going back to the question, this was the best answer, I would say. Now here, there was a slight amount of confusion in this question and the recalls. A child with a patch of alopecia, some students mentioned it was incomplete alopecia written here. So a child with a patch of incomplete alopecia with itching, sibling also has similar lesion. Scraping from the patch is shown below. Identify the organism. So again, we come to our DDs of patchy alopecia. I always tell you, whenever you get a question on alopecia, as per the pattern, make your DDs, helps you choose your answer. So in patchy alopecia here, alopecia areata, tinea capitis, trichotillomania. Since it is associated with itching, it has incomplete hair loss. Sibling has similar disease which would indicate an infection. We are dealing with tinea capitis here. Now when you're dealing with tinea capitis, it could be grey patch tinea capitis, it could be black dot tinea capitis, it could be favus, it could be chirion. Now chirion would be a red boggy swelling, that is not mentioned here. Favus would have a lot of crusting, plus it is not so common, again not mentioned here. So you actually have to choose between grey patch and black dot tinea capitis. So let us see what the smear is showing us. So in the smear we see that these are the fungal spores here, as you can see. So these are all fungal spores here. Where are fungal spores present? They are inside the hair or outside the hair. So if you look at this image again, all these fungal spores are present within the hair. So this is the hair, this is the hair. The spores are present within the hair shaft. So if they are present within the hair shaft, what kind of hair involvement is this? Within means endo. So this is an endothrix type of infection. So in these two types of tinea capitis here, grey patch or black dot, where do you see endothrix involvement? Let's go back to the mnemonics that we have done during the class. With grey patch, I tell you GMC. With black dot, I tell you BNT. Where G is for grey patch, M is for the microsporum which cause it, C is for the ecto. So GMC, that is grey patch, has an ectothrix type of involvement, while black dot has B. N is for endo here, T is for the trichophyton fungi which cause it. So if this is an endothrix type of involvement, where do you think it goes? It goes to black dot type of tinea capitis. Could be caused by a trichophyton fungus. Come to the options here now. In the options, epidermoflocosum, this cannot be the answer because E doesn't affect H. Epidermophyton does not cause hair infections. Microsporum canis, Trichophyton violatium, Trichosporon does not cause it. Okay, it is a superficial fungal infection, separate, it does not cause hair involvement. So Microsporum canis and Trichophyton violatium, which of these? So B and T has T. So the correct answer here would be T, that is Trichophyton violatium. While Microsporum canis would be causing grey patch, not black dot. Coming to the quick revision here, I have just told you the mnemonics. So look at black dot here. The patient will have incomplete alopecia with multiple black dots on the surface. In the smear, you will see endothrix type of involvement, while in grey patch, that is the ectothrix, you will see smears outside the hair shaft. So this is an important thing that you have to remember. You know, it is for the first time that they have actually asked KOH of the hair. So it was a relatively new thing to ask, I would say. But if you know how to read your smear, see whether the spores are inside or outside, you can attempt this question well. So coming to the next question, a farmer presented with foot swelling, discharging sinuses, stain from the lesion showed gram-positive filamentous structures, which in some recalls I have been told by students, it is also mentioned as gram-positive branched filamentous structures. What is the causative organism? So whenever farmer with a foot swelling with discharging sinuses comes, you know you are dealing with mycetoma. So that is one thing which is clear from the history here. Mycetoma could be eumycetoma, where it is a fungus causing it. It could be actinomycetoma, where a bacteria causes it. Now, the clinical features are same. So how do you differentiate? You see the color of the grains, you do the gram stain, the culture, the biopsy. Yes, but here what we have mentioned is gram stain. So whenever it is eumycetoma, the finding that would be seen is gram negative hyphae. While in actinomycetoma, what you would see would be gram positive filamentous bacteria which give a sun-ray appearance. So what matches the question here? Gram positive filamentous structures. Yes, branched is mentioned. That may confuse some students to mark it as hyphae, you know, because you generally read branching hyphae. But you see what is mentioned here. This is gram positive. Gram positive is seen in actinomycetoma. So in the question here, what are the causes? Nocardia brasiliensis, yes, it is definitely a cause of actinomycetoma. Sporothrix shinkai causes sporotrichosis, completely different clinical picture. You will not even consider it here. Aspergillus causes eumycetoma, again not you would consider based on the gram stain findings. There is one confusion here which a lot of students had, the word Staph aureus. Gram positive could take you to another mycetoma like swelling which is called as botryomycosis. This is caused most commonly by Staph aureus, and here also there could be a person with a foot swelling with discharge from it. The stain would show gram positive cocci. It would not show you filamentous bacteria. So you do not mark Staph aureus here. The correct answer to this question is option A, that is Nocardia brasiliensis. So even though the clinical features of the painless swelling with discharge with granules are the same, the gram stain findings as shown here are different. Gram negative hyphae in eumycetoma, while the sundry appearance of the filamentous bacteria in actinomycetoma. On the other hand, if it was botryomycosis, which is caused by Staph aureus, you would see similar swelling with nodules on it, with discharge, but it would be gram-positive cocci. These are some other commonly asked questions. See, sporotrichosis would be linear nodules in a lymphoid pattern, not what the question says. Chromo is cauliflower-like growth on the foot with copper penny bodies. Very important, very often repeated. Like one question from the subcutaneous mycosis is asked almost every year, I can say. So very important to know these 4-5 infections properly. Question number 14, this is a repeat from NEET PG 2021. A patient presented with painful urethral discharge. What is the management? So a painful urethral discharge, what does this mention? This means that the patient has pain. There may be pain during micturition also, which would be dysuria with urethral discharge. What is the kind of discharge here? Here you see a purulent discharge coming out of the urethra. So this is a purulent discharge with dysuria. Where do you put it? You put it as a diagnosis of gonococcal urethritis. So the pus here tells you that the patient has gonococcal urethritis. What is the treatment of choice for gonococcal? Ciproflox, it's not the treatment of choice. Azithromycin, no. Doxycycline is for non-gonococcal urethritis. Cefixime is the correct answer for treatment of gonococcal urethritis. So how do you get it? In gonorrhea, you see this profuse purulent discharge with periurethral erythema, intense pain during micturition, which is dysuria. When you make a gram stain, you see these gram-negative intracellular diplococci. You confirm your diagnosis. Treatment is, as per the CDC guidelines, only ceftriaxone. Now, there is no role of azithromycin in the treatment of gonorrhea. So, injection ceftriaxone 500 mg IM stat. If the patient cannot take an injection, you give tab cefixime 800 mg stat. So, please see the doses are a little different from what may be there in your previous Q banks. Coming to non-gonococcal urethritis, most commonly caused by chlamydia trachomatis D2K, but it can also be caused by other organisms like ureaplasma, mycoplasma, trichomonas, herpes genitalis. All of this you should have in your mind if there is a question on non-gonococcal urethritis. Here there would not be so much of a dysuria, plus the discharge is more mucoid. It's a clear discharge, very less in amount, scanty discharge. More often than not, patient doesn't even know they have it. It remains asymptomatic. They do not seek treatment, which helps it spread rampantly amongst the population. So this is non-gonococcal urethritis. If the diagnosis is made using the nucleic acid amplification test, you confirm it, you give the patient doxycycline 100 mg BD for 7 days. Again, please remember, as per the previous guidelines, azithromycin was the DOC. No longer it is doxy, which is the drug of choice for NGU. A sexually active woman presented with foul-smelling watery discharge. What is the causative organism? This is like a favorite with the NEET, with the INI, with the FMG. Every year, 2 or 3 exams have this question. What do you think when this is a foul-smelling watery discharge? We just discussed when we were doing the question on trichomoniasis. Foul-smelling watery discharge means bacterial vaginosis. Bacterial vaginosis is definitely not caused by Candida or trichomonas. Lactobacillus actually reduces here. What causes it is option A, that is Gardnerella vaginalis. The population of Lactobacillus reduces, Gardnerella increases. So this is an alteration of the bacterial flora. There is a foul smelling vaginal discharge. The pH increases to more than 4.5. There is a positive whiff test. That is, you take a slide, you put the discharge on it plus a few drops of potassium hydroxide, you get a fishy ammoniacal odor. That is called as the whiff test. And lastly, clue cells, but the percentage is important here. It has to be more than 20%. Image of clue cells is also very important. These are vaginal squams studded with gram-negative bacilli, which are Gardnerella. Since Gardnerella is a commensal, some amount of clue cells will already be present in the vagina. It is only when Gardnerella increases, your clue cells increase. That is why it is percentage more than 20%, which is included in the AMSELS criteria. 3 out of 4 are required to make a diagnosis of bacterial vaginosis. Treatment of choice, metronidazole. A 60-year-old patient released from leprosy. So this is a word that we used, released from treatment, for patients who have finished their leprosy kits. Okay, so they are released from treatment. Now presents with a painless punched out ulcer on the sole. What is the management? Now, patients of leprosy have sensory loss. They also have autonomic neuropathy. All of this causes a problem with their gait, a problem with perception of threads. They may end up with traumatic ulcers on the foot. They may even end up with trophic ulcers. So trophic ulcers are very common in patients with leprosy, especially the ones who had LL leprosy. Now see, in this patient here, a painless punched out ulcer on the sole is a classic trophic ulcer that you see in patients with leprosy. It is a grade 2 deformity. Now, since it is clean, it is painless, it is punched out, the base looks fine, there is a granulation tissue a little bit you see on the base, it does not appear like an infective ulcer. So we deal it with as a trophic ulcer. Would you give intense debridement and IV antibiotics? No, not at all. Would you amputate? No, not required. We would rather like to treat the ulcer. Would you restart MBMDT? Not at all. The patient has finished their kits for just an ulcer, which is a deformity. Why would I start treatment again? No. Ask him to bear less weight on that leg? Yes, because trophic ulcers heal better when there is more vascular supply, lesser weight bearing. So you would treat the patient with dressings, maybe a minor debridement of the tissue on the margins, dress it, ask them to bear less weight, and gradually over time the ulcers will heal. Plus also in these leprosy patients, a very important part of their treatment is counseling about avoidance of trauma, to wear proper footwear. In leprosy patients we give MCR footwear, which is a microcellulose rubber. It has raised edges on all sides. This is like a special footwear made in leprosy hospitals. We refer the patient there, they give their size, it is made as per their size, they have to wear it. So it protects them from the stones and the pebbles on the road, the minor trauma which they would otherwise not perceive because they already have sensory loss. And it also has an even weight distribution, so helps in preventing trophic ulcers from happening also. So MCR slippers, these are microcellulose rubber slippers. These are specially made for leprosy patients. So in this patient here, I would advise him to bear less weight on this leg. Last question, I do not have the proper recalls with this one. It was a child with photosensitivity with multiple skin cancers, and it was asked what is the defect seen. So when there is a child with photosensitivity and skin cancers, you have to think of xeroderma pigmentosum, and the defect here is in the DNA repair. That is a nucleotide excision repair defect. The inheritance for this is autosomal recessive. Treatment requires strict photo prevention to prevent skin cancers from happening. So with this, we finished the recall. I hope all the questions were actually what they were asked in the exam. It was a little difficult collecting the recalls this time, but if there are any changes that you want to make to the questions or the options, please put them in your feedback or in the comments. And all the best for your result. For the ones who are studying, study as well as you can. This exam requires all the effort that you can put in. All the best.